everyone, we're back with another episode of Infectious Conversations. This is WVU Medicine's official infectious diseases podcast. I'm your host, Dr. Mira Mehta. I'm a clinical infectious diseases pharmacy specialist, and today we've got an amazing guest with us, Dr. Bailey Burnette. Bailey, thank you so much for being on the show today.
Having me, Mira.
Of course, and Bailey, if you want to tell all the viewers at home what your role is at WVU Medicine.
Yeah, so I'm currently a third-year internal medicine resident, and I'm going into our ID fellowship here in July.
Super excited about you being in the ID fellowship. Yeah. And Bailey, every guest on the show, I have to ask for a fun fact. So what is your fun fact for the day?
Yeah, so actually, me and Mira were at ID Week a few years ago, and we did a Beverly Hills tour. So that was a lot of fun.
Yeah, it was really fun. Yeah. They said that Dwayne Johnson appeared on that tour previously, but we didn't get to see him. So I was so bummed.
We saw no famous people, but that's okay.
Maybe next time.
Maybe it's us.
So, Bailey, we're here to talk about Lyme disease today, and I think this episode is very, very timely because summer's just around the corner. Yeah. West Virginia is known for the great outdoors and hiking, yes. And if you're anything like me, you're going to be spending a lot of time outdoors. But with that, we have to watch out for those sneaky ticks that are around, and as we know, they can spread Lyme disease. So, Bailey, what is Lyme disease and how is it typically spread?
Yeah, so Lyme disease is an infection caused by a spirochete, a bacteria called Borrelia burgdorferi, and it's spread by the black-legged tick, or deer tick. Some people call it deer tick. That's kind of easier. And then the scientific term that we use is Ixodes scapularis. And so essentially it feeds on mice, that's like the reservoir, and then it'll feed on us humans. And whenever it ingests our blood meal, then it will then transfer the infection. However, it typically takes about 36 hours for that bacteria to actually be transmitted to us.
Yeah, okay. Thanks for that insight. So I've been reading in the news that the Lyme disease is going to be at record high numbers. So why is it projected to be so bad this year?
Yeah, so I was very curious as to that too, because I've been hearing it's going to be bad, and I'm like, it's already bad. I feel like every summer, at start of residency, we're seeing so many cases of Lyme disease in the hospital. But looking into it, the CDC actually tracks how many ED visits are for tick bites. So it's only including people who actually go to the ED, but within this year so far, 48 per 100,000 ED visits have been for tick bites.
Wow.
Yeah, and that's within the Northeast region. And I know us West Virginians probably don't consider ourselves Northeast, but we are included in that geographical range for their analysis. But then within the month of April, it's been 96 per 100,000 ED visits across the U.S. So that's why they're very concerned. Again, that's not capturing everyone who gets a tick bite too.
Right. And I was reading that some of the reasons for this is that the weather's getting warmer, so ticks are coming out earlier and they're staying out for longer. And then warmer winters mean that a lot more ticks are going to survive over the winter.
Exactly.
I saw that anywhere from 1% to more than 50% of ticks carry Lyme disease, which I thought was really interesting. And their lifespan, their lifespan is anywhere from 2 to 3 years. So definitely, it's the perfect cocktail for those number of cases to be rising.
And that brings up a good point, too. Summer, of course, we think of Lyme disease and tick bites, but really they can happen throughout the year. Yeah. So watch out if you're an outdoors person in the winter or if you have animals, because they can drag in those pesky ticks.
Yeah, you got to be on your toes for sure. So another thing that I wanted to ask is if anyone's listening at home, let's say that they see a tick on them, what should they do? How should they approach that?
Yeah, so what you want to do, of course, is remove it. But there is a proper technique. Very simple. Just use some tweezers, and you want to grasp close to the skin where the head is. And they have remarkable grip strength.
Yeah, I've heard.
So you want to fatigue it a little bit, give it a few like slight tugs, and that should give it some fatigue, and then you can remove it. I have been told in the past, I guess wrongly, but you don't want to use any like petroleum jelly. That's not necessarily recommended. And definitely don't use any like flames or anything. That's some folklore that's been out there. Yeah, don't use any flames.
That'll lead to a whole wide range of other problems that we don't want. Yeah.
Definitely not.
Well, I've been lucky enough not to be bitten by a tick yet, but if I do, I will keep all of that in mind. So if somebody does see a tick, and you were saying that the timing of how long it stays on is important, but if somebody sees a tick, do they need any prophylaxis at that point?
Yeah, so there's actually pretty strict criteria if a patient should have prophylaxis. It's really just a one-time dose of doxycycline, 200 milligrams, but you need to be in a region that's like endemic for Lyme. And then also you have to have a deer tick that's been attached for 36 hours, which people are like, how would I know if it's attached for 36 hours? I just found this. But if it's engorged, then you need to be concerned. And then you need to be able to take that doxycycline within 72 hours of removing that tick.
Okay, so it has to be within that time period.
Yeah, after you removed it.
That's good to know. So some people that may be listening, I know you mentioned the drug doxycycline, and that's one of our most commonly used outpatient antibiotics. And some people may be thinking, well, doxycycline, that doesn't sound that bad. And so what's the big deal if somebody does get bitten by a tick with Lyme disease and doxycycline can treat it? So can you tell me a little bit more about the signs and symptoms of Lyme disease and also some downstream complications of it as well?
Definitely. So I think, you know, the public is fairly aware of like the bullseye rash that we talk about, or erythema migrans. And my father so kindly let me use a picture of him from back in 2020, where he actually thought he had COVID, but went to go see the doctor. And sure enough, he had a big old bullseye on his back that he wasn't aware of. So that's what about 80% of people present with early localized Lyme disease. Now, you might not have that bullseye. It's only 80%. You might have fatigue, malaise, arthralgias, myalgias, just generally not feeling well. And if you have a tick exposure, then that puts you at risk for, you know, potentially having Lyme with those symptoms. But the scarier side of Lyme is really the early disseminated, which occurs like weeks to months after you get exposed, or late disseminated. And that's where you can have Lyme carditis causing heart blocks, so heart arrhythmias that, you know, you might present to the hospital and say, hey, I've got some heart palpitation. My heart doesn't feel right. They do an EKG, and sure enough, you're in like second, third degree AV block. And I've seen multiple of those during my residency, and they end up with a transvenous pacer. And then also Lyme meningitis can be really scary too, obviously. So that presents in about like 15% of patients that aren't treated by the time, you know, they have the meningitis. So
yeah, so there are some serious complications in some cases for sure. So how do we manage treatment of the disease?
Yeah, so with early localized, you just need doxycycline for 10 days. It's just twice daily that you take the doxycycline. You can also use amoxicillin or cefuroxime as well if you have allergies or reasons not to use doxycycline. But then when you get into, that's just the early localized, but whenever you get into the early disseminated, late disseminated, that's where you have to kind of tease out, and it's a little more patient directed. So if a patient's in like third degree heart block or has a very prolonged PR interval, which we look for heart blocks, if they have like a first degree block, then they really probably need hospitalized and need to start on IV ceftriaxone. Later in the admission, they can be transitioned to doxycycline, but that's on a patient-to-patient basis. And you'll treat for 14 to 21 days. Now for like Lyme meningitis, you need to treat for 14 to 21 days, but the IDSA guidelines recommend doing it completely with ceftriaxone, with IV ceftriaxone.
Sure, definitely. Yeah. And one of my roles here at WVU Medicine is I actually helped start the OPAT program, Outpatient Parenteral Antimicrobial Therapy. So that's a program where anyone who is going to be discharged on long-term antibiotics, 14 to 21 days fits in that. We actually have a program that will dose and monitor that patient throughout their whole IV treatment course. And I will say we definitely do every year get cases of Lyme carditis and Lyme meningitis too, where we're using IV ceftriaxone for a prolonged period of time. So definitely does happen in some cases. Another common theme is doxycycline. So I do just want to, as a pharmacist, want to draw attention to some counseling points. So doxycycline can cause photosensitivity. So of course, if you're going to be out in the sun, you definitely want to be sure to wear sunscreen or wear a hat, and that way you won't get some type of sunburn while you're in the sun. Sometimes it can cause GI upset. So that's another thing to keep in mind. You can consider taking it with food. And then another interesting thing about doxycycline, they recommend not laying down 30 minutes after taking it, because sometimes it can cause some GI upset there. And then there is a drug interaction between doxycycline and what we call polyvalent cations. So that's things like iron or calcium, things that would be in Tums, for example, or if you're taking an iron supplement. And so if you're taking those while you're on doxycycline, it's just important to tell your pharmacist, and you'll have to separate those out. Otherwise, the efficacy of doxycycline might be reduced. So you said that 80% of patients tend to show that rash. In the remaining 20% that don't have the rash, how do they get diagnosed?
Definitely. So as you said, the 80% who have the very typical, not all rashes in Lyme disease look as picture perfect as the bullseye, right?
Yeah.
So you might have a rash and you're like, oh, I don't know what's going on, but later find out. And it's through serological testing.
Okay.
Yeah. So typically it's a 2-tiered serological test where you do an enzyme immunoassay or immunofluorescence initially. And then if that's positive, you go down to the 2nd-tier test. I won't get into the nitty-gritty of interpretation of that today, but that's how you do a diagnosis if you don't have the typical bullseye rash. Now, if you do have the bullseye, then you can make a clinical diagnosis.
Okay, so that serologic testing is kind of our backup option. If somebody's been adequately treated, so they got their proper course of antibiotics, whether that be oral or IV, but they're still having symptoms after that. So we're talking about a long time after exposure, they're still having symptoms. What's the recommended management in that situation?
Yeah, definitely. First off, I want to say, let your doctor know, because if it's a very objective sign of infection, then you need to be considered for possible extension. But if it's just generalized fatigue, malaise, maybe some slight joint pain, I'm not talking about a red hot swollen joint, but just generalized some joint pain, then that's what we call post-treatment Lyme syndrome. And really, it's just supportive care. We don't see benefit with giving additional antibiotics in those scenarios.
Yeah, and that's another key part of being a good steward and performing antimicrobial stewardship. At that point, more antimicrobials really aren't going to help. And really, the disease state has moved from infection to inflammation at that point, for sure.
Definitely.
So sometimes the best treatment is prevention. So what can we tell our viewers at home about preventing the tick bites?
So, of course, when you're going outdoors, you just need to be aware that you are exposing yourself. I love hiking throughout West Virginia so much. And thankfully, I only ever had one tick bite, and it was in Maine, so not from here. But you want to wear long pants, long shirts and socks, making sure, it limits the bite area for the tick. And then after you go indoors, make sure you're doing a full body check. And I'm talking full body. Yeah. They like to go in kind of the groin area, axilla, or hide out there at least. And look at your hairline too. People often forget, you can't have tick bites there. And then get a good shower. No matter what, get a good shower. Yes. But while you're outdoors too, you can use DEET, permethrin, those sorts of things. I saw some things about lemon eucalyptus. That was, if you like the more natural, there is some data on that as well. And then if you have animals, you want to check them for ticks, and then, make sure you're doing frequent checks of yourself to make sure you don't have ticks. Yeah.
Well, Bailey, thank you so much. We really appreciate all of that information about Lyme disease, and hopefully everybody stays safe this summer. Well, thank you so much for tuning in to the latest episode of Infectious Conversations. I was your host, Dr. Mira Mehta, and our expert today was Dr. Bailey Burnette, and we hope that you join us for our next episode. Thank you.